Hello, thank you for watching my presentation today. My name is Kelsey Brodsky and I am a student physical therapist at the University of St. Augustine for Health Sciences. Today I'm going to talk about a patient I recently evaluated who came in with left low back pain after getting injured in a soccer game. According to Grosvenor et al. In the Journal of Sports Sciences 2016, 47% of elite soccer players suffer from low back pain during the previous year and show a decrease in lumbopelvic motor control. However, it is unclear whether low back pain causes the decreased motor control or if the decreased lumbopelvic motor control leads to low back pain. The purpose of this presentation is to discuss possible tissue impairments from soccer injuries and how they can affect function, as well as discuss evidence-based treatment plans specific to the impairments of the individual. My patient was a 25-year-old ectomorphic female who was injured during a soccer game 2 weeks prior to coming to physical therapy. She was up in the air trying to hit a ball when she was knocked off balance and landed on her back. Her chief complaint was left low back pain that she described as being achy, sore, and stiff. She had immediate pain after the fall but continued to play the rest of the game. She didn't seek out any medical treatment, so there was no imaging or a medical diagnosis available. The patient thought it would resolve on its own with self-treatment of ibuprofen and ice. These strategies reduced the pain temporarily, but her low back pain continued to return. I used the numeric pain rating scale, NPRS, to quantify the patient's pain. This scale is rated from 0 to 10, with 0 being no pain at all and 10 being the worst pain in my life. I need to go to the emergency room right now. The NPRS is shown to have excellent inter-rater reliability and validity, according to Herr et al. Clinical Journal of Pain in 2004. The patient reported pain anywhere between 1 to 6 out of 10. Pain was made worse with running, playing soccer, and after long days of work. Patient occupation is a high school teacher, so she is up on her feet for long periods of time during the day. Her back pain was made better with ice and ibuprofen, and she was most comfortable when lying on her back. Patient is not taking any other medication besides the ibuprofen and birth control. She denied any radicular symptoms, so no paresthesia, numbness, or tingling. Past medical history showed the patient experienced a similar injury a year ago and underwent physical therapy for treatment. She went for 4 weeks and received soft tissue massage to relieve the pain and worked on strengthening her lower extremities. Patient said the pain disappeared after therapy and she returned to her normal activities. Before this injury, patient's prior level of function was long-distance running, averaging 6 miles a day, playing soccer 3 to 4 times a week, and teaching 5 times a day. She's currently only running 3 to 4 miles a day and plays soccer with limited contact. All of these activities produce pain during and a few hours after activity. Patient's goal is to have no pain or limitations with running, playing soccer, or teaching. The patient-specific functional scale is an outcome measure I use to assess her functional progress throughout the treatment. This scale has the patient choose 3 functional activities she feels limited in and rates them on a scale from 0 to 10. Then I take the average of these 3 scores. 0 means she was unable to perform the function, up to 10, which means she could perform the function completely normal with no limitations. My patient chose running, soccer, and teaching as her 3 activities. She had an average score of 7 out of 10, which means she perceives herself as having a mild functional limitation in those activities. According to McGon and Lewis in the European Spine Journal 2010, the minimal clinically important difference for the patient-specific functional scale is 2 points and has excellent inter-rater reliability. Therefore, we're looking for a 2-point change in the average score when the patient rates her functional ability for these 3 activities later on, in order for it to be a valid change in pain and function for her. In the objective findings, I found upon initial examination and standing that the patient's left anterior superior iliac spine was higher than her right. She leaned slightly to her right and had an increased angle of inclination between her posterior superior iliac spine and anterior superior iliac spine, putting her in increased anterior tilt. When performing active range of motion, the patient had reproduction of pain and 25% range of motion limitations in extension and left side bend. Flexion was limited by muscle restriction, right side bend and rotation to right and left were normal. Passive range of segmental mobility was performed on the lumbar and thoracic spine. Hypermobility was found at L4-5 in all directions, and hypomobility at L3-4 with flexion and extension and left side bend. Generalized hypomobility in the thoracic was found in T5-6 and T9-10 segments. Neurovascular and upper quarter screen was unremarkable. Lower quarter screen revealed tight 2-joint hip flexors and hamstrings on the right, as well as weak bilateral hip abductors and external rotators, and weak transversus abdominis. Sacroiliac joint range of motion and pain screen was performed with significant findings of a positive lag test on the left and positive knee to chest on the right, revealing the right ilium is posteriorly rotated. No diagnostic imaging was performed, as the patient did not seek out medical attention prior to physical therapy, as previously said. My physical therapist diagnosis for this patient, using the International Classification for Function, is subacute low back pain with a mobility deficit. Patient's long-term goal is that in 4 weeks she will have 0 to 10 pain with no range of motion limitations to allow her to return to her prior level of running, playing soccer, and teaching. I compiled an impairment list based on examination and it is ranked by level of importance. Each impairment also lists the interventions chosen using evidence-based research. The main impairment found was facet capsule hypomobility of L3-4. Clin J et al. And the International Journal of Sports Medicine 2012 found that spinal manipulation improves clinical outcomes by reducing pain and increasing mobility. Hypomobility of T5-6 and T9-10 will also be addressed with spinal manipulation. Right posterior rotation of ilium will be treated with anterior rotation manipulations to the right ilium. The hypermobile joint of L4-5 and weak transversus abdominis will be treated together with strength exercises of transversus abdominis to stabilize the trunk. Lumbopelvic motor control will be improved through neuromuscular reeducation. Herr et al. In the Scandinavian Journal of Medicine and Science and Sports 2010 showed that motor control of transversus abdominis and pelvic floor decreased athletes' low back pain by 50% and allowed them to progress to higher load functional activities. Tight right 2 joint hip flexors and hamstrings will be treated with stretching. Contract relaxed stretching has been shown to be the most effective for immediate increase in flexibility of restricted tissue, based on the systematic review by Cayco et al. In the Physical Therapy and Sport Journal 2019. Finally, we will address the weak bilateral hip abductors and external rotators with strengthening exercises. According to Majolsnin et al., Scandinavian Journal of Medicine and Science and Sports 2004, eccentric strength exercises develop maximal strength compared to concentric exercises. Therefore, we will focus on eccentric exercises to strengthen the hip abductors and external rotators. Prognosis for this patient is excellent. The patient is young, active, and lives a healthy lifestyle. She is a motivated athlete who's determined to get back to her activities. Patient also had a similar injury about a year ago and got better with physical therapy, so she knows what it takes to improve her condition and trusts that physical therapy will work. Most people think of soccer players as only having injuries of the ankle or knee, and although that is very prevalent, Grosvenor et al. Journal of Sports Science 2016 reported annually that there are still 6 to 18% of injuries due to trunk or groin, with 53% of players reporting low back pain later on in life. It's important that as physical therapists, we look for lumbopelvic motor control impairments in soccer players, even if they are higher-level athletes and known to be coordinated, and to address this earlier to possibly prevent future low back pain. This presentation describes how to pick out impairments through examination and develop an individualized treatment plan supported with evidence-based research in order to provide the best care for your patients. I hope you enjoyed this talk, and thank you for attending my presentation.